What you are looking at is the exact mechanism of a heart attack in the making. High levels of circulating LDL cholesterol do not float harmlessly in your blood. Over time, they directly embed into your artery walls, building up as thick, hardened plaque. This cumulative plaque burden drives atherosclerotic cardiovascular disease, the leading cause of global mortality. Clinical data shows that the benefit of lipid-lowering therapy is proportional to the absolute magnitude of reduction achieved. When we lower that LDL number, the risk in a cardiovascular event drops alongside it. This is a hepatocyte, a human liver cell. For decades, the standard for fighting cholesterol has been moderate-intensity statins, which work right here, inside the liver, blocking the enzymes responsible for synthesizing cholesterol. As a baseline intervention, they are effective. A standard statin regimen reliably reduces a patient's circulating LDL cholesterol by 30 to 50%. However, that percentage has a ceiling. For patients with high baseline risk or genetic predispositions, a 50% drop often isn't enough to reach the aggressive LDL targets required by modern guidelines. Lowering LDL is a robustly validated way to reduce cardiovascular risk, but for many, relying on statins alone is no longer the most effective path to prevention. This creates a clinical dilemma. What happens when a patient is already at a 50% reduction, but their absolute risk remains too high? This graph illustrates the problem. It is governed by the rule of 6. If you take your current statin dose and double it, you do not double your results. You only gain about a 6% additional drop in LDL as the efficacy curve flattens out. Biology drives this pushback. When statins suppress cholesterol synthesis in the liver, the body compensates by absorbing more cholesterol through the gut. Pushing for a high-dose regimen increases systemic drug exposure for a very small gain in biological benefit. A rational combination strategy offers a different path. Instead of maximizing one drug, we stack different classes to attack the cholesterol pipeline from multiple angles. The most frequent example is pairing a moderate-dose statin with a drug called ezetimibe. Ezetimibe works in the small intestine. It binds to the transporters responsible for dietary cholesterol, neutralizing the body's compensatory response to liver-directed therapy. By blocking both the liver and the gut, this two-drug combination yields a 60 to 65% LDL reduction, while allowing the patient to stay on a much lower statin dose. Targeting multiple biological pathways simultaneously produces better results with less total chemical exposure than dose escalation. Some cohorts require even more significant reductions. Patients recovering from a heart attack or those with severe genetic cholesterol burdens often need to clear the majority of LDL from their blood. For these high-risk cases, we use PCSK9 inhibitors. These agents prevent the destruction of the liver's LDL receptors. Look at this comparison. By keeping those receptors active, the liver becomes more efficient at clearing particles. When paired with a statin, this combination can remove up to 80% of circulating LDL. The trade-offs are logistical. PCSK9 inhibitors require injections every few weeks or months, and they currently carry a higher financial cost.
For those who need similar efficacy but prefer an oral medication, bempedoic acid is an alternative. It operates on the same pathway as statins, but it blocks cholesterol synthesis 2 steps earlier, adding a roughly 20% further reduction. Its defining feature is tissue selectivity. Bempedoic acid requires a specific enzyme to activate, an enzyme that is undetectable in human skeletal muscle. Modern pharmacology can now achieve profound LDL reduction while physically bypassing muscle tissue, addressing the most common historical hurdle to cholesterol treatment. Yet there is a distinct clinical paradox. Despite the availability of life-saving drugs, 10 to 20% of patients discontinue therapy because of muscle aches and fatigue. This abandonment represents a significant loss in preventive cardiology, as many patients remain unprotected against heart disease, despite having the means to treat it. It has long been assumed that lipophilic statins, which can passively diffuse into muscle cells, cause more pain than hydrophilic statins, which are more liver selective. However, data from double-blind randomized trials show nearly identical muscle symptom rates, regardless of whether the statin is lipophilic or hydrophilic. To resolve this, researchers conducted the SAMSON trial. They tracked 60 patients who had previously quit statins due to side effects and monitored them across 3 different conditions. Over 12 months, patients rotated through 3 states: an empty bottle, a placebo pill, and an active statin. The study calculated a nocebo ratio.
patients reported a pain score of 8 when taking nothing and 16.3 when taking the statin. But when taking the sugar pill, their pain score was 15.4. 90% of the symptoms induced by the drug were exactly reproduced by the placebo. These patients were not imagining their symptoms.
The pain was real and, in many cases, intolerable. But the results suggest that for 9 out of 10 patients, muscle intolerance is triggered by the expectation of side effects rather than the chemistry of the molecule. This decision tree organizes these tools into actionable paths to reach your target LDL. Profile 1. The optimizer. You're tolerating a standard statin well, but you are still above your LDL target and want a simple, cost-effective way to get there. Instead of doubling your dose, add ezetimibe to target a different pathway, dropping LDL further without increasing statin exposure. Profile 2. The athlete. You're sensitive to energy changes or have noticed a decrease in peak exertional power since starting therapy. Look toward muscle-sparing classes like bempedoic acid or PCSK9 inhibitors. They physically avoid skeletal muscle cells. Profile 3. True intolerance. This is a patient with objective proximal weakness and marked CPK enzyme elevations that don't resolve after stopping the drug. This is a sign of INNM, a rare autoimmune condition. This requires permanent avoidance of statins and a switch to non-statin therapies like ezetimibe, bempedoic acid, or injectables. For most patients, reviewing your own objective symptom data allows you to distinguish between a nocebo response and a true pharmacological one. By combining these strategies and understanding the data behind side effects, we can lower cardiovascular risk to its lowest possible level with confidence.